Hello, and welcome to today's webinar, Addressing the Intersection of Substance Use and Suicide, Strategies for Prevention, Intervention, and Treatment. I'm Tracy McPherson, and I'll be your moderator for today's event. If you have any questions about this webinar or any webinar in our series or information, you're looking for information on screening and brief intervention, you're welcome to contact me at the email address on your screen. This webinar is produced in partnership with the University of Cincinnati, NORC at the University of Chicago, the BIG Initiative, and the Adolescent Expert Project, which is funded by the Conrad N. Hilton Foundation. If you'd like to learn more about our partnership and our work, you can visit our website at expert.webs.com. And if you have any questions about our initiative, you're welcome to email the expert team at expertteam@norc.org. This presentation is supported by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services as part of an award totaling $397,935 with 0% percentage finance with non-governmental resources. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. For more information, you can visit hrsa.gov. And with that, I'd like to start by getting to know a little bit about our audience today. So we're going to start with our first polling question. Please select your answer on your device, and we will talk about it in a minute. The question is, are you a Health Resources and Services Administration, or a HRSA grantee? And if so, what kind? A behavioral health workforce education and training grantee, opioid workforce expansion programs for professionals, an area health education center, other type of HRSA grantee, or you're not a HRSA grantee at all? Great. Well, thank you for answering our first poll question. It looks like we have quite a mix of HRSA grantees and non-HRSA grantees. So welcome, everybody. And with that, let me share with you the information about the materials today. So to access the materials, you can download the PowerPoint slides and other resources on our website at expert.webs.com/substance-use-and-suicide. So this is a dedicated web page that contains the PowerPoint, any additional materials and resources that may be mentioned today. And this is where you're going to find the on-demand recording that's available 24/7. In addition to that, when the webinar concludes, you're going to receive a follow-up email from us that contains all the instructions for watching it on demand and obtaining a free certificate of attendance. If you wish to ask a question, you can do so by typing into the questions pane in your GoToWebinar control panel on either your computer or your mobile device, and someone from our staff will respond to you as soon as possible after the webinar concludes. So with that, I'm pleased to be able to share with you today the expertise of Dr. Brett Harris. Dr. Harris is the Director of Public Health Initiatives at the Suicide Prevention Office of the New York State Office of Mental Health. And in this role, she oversees initiatives related to schools, colleges and universities, communities, and the relationship between substance use and suicide, and works with large health systems and community providers to integrate suicide-safer care into multiple service settings. And Dr. Harris is also a clinical assistant professor at the University at Albany School of Public Health, where she teaches a course in suicide prevention, and she collaborates on alcohol and drug prevention and early intervention projects. Prior to joining OMH and the University at Albany, Dr. Harris developed, implemented, and evaluated alcohol and drug screening, brief intervention, and referral to treatment projects with the New York State Office of Alcoholism and Substance Abuse Services, fondly known as OASIS. And Dr. Harris serves on the board of directors of the New York State Public Health Association and was selected for the Dobamont Foundation's inaugural cohort of 40 under 40 public health leaders. Dr. Harris received her Doctor and Master of Public Health from the University at Albany and her Bachelor of Science from Cornell University. So with that, welcome, Dr. Harris. Glad you were able to share with us today your expertise in this area. And so what I'm going to do is turn it over to you to get us started.
Thank you, Dr. McPherson, and thank you everyone for joining us today for this webinar. Okay, so I just wanted to start off by putting this into context. With the current pandemic, we know there's been a huge public health impact and a real impact on physical health. But we know from the research on just pandemics in general is that mental health, there are huge mental health impacts that follow those physical health impacts, and they're long lasting. We've been putting an emphasis on mental health, recently in New York, where I am, and we know that we're trying to really bring awareness to this and provide supports, and we are definitely expecting. We know there's been a mental health impact already, and are expecting this to be long lasting. And we also know that there's been an uptick in opioid overdose deaths. And just overdose deaths in general, and and substance use. So this is really important to us, and this area is important for us to focus on all the time, really, but particularly now. So I think this is very timely. So this is going to be a very comprehensive webinar, and I just wanted to start out with an outline so you guys know what's coming up. And I know that this webinar is going out to the substance use prevention, intervention, and treatment community. So I wanted to provide a pretty good background on suicide as a public health problem, and then go into really how suicide intersects with substance use. And then providing a kind of a public health approach here by starting off discussing substance use and suicide prevention in communities. And we conducted a recent study actually in New York that I wanted to share. And then suicide safer care protocols for healthcare settings. So, general medical settings as well as substance use disorder treatment settings. And then I know a lot of you are familiar with the SBIRT model. And we know that we try to increase the uptake of SBIRT. Those of us in the SBIRT field know that we'd like it to be done more often, but for those of us in the suicide prevention field, we think that SBIRT's pretty robust. So we want to build on the infrastructure of SBIRT to integrate suicide prevention into that model, because the two issues really do intersect, and the elements of suicide prevention in healthcare are very similar to that of the SBIRT model. All right, so one of the things we note here is that in public health, there's a number of different, it's very broad, and there's a number of different issues that we focus on, and suicide has been increasing, steadily increasing, while some of these other key issues have been decreasing. Mental health in general, but suicide prevention specifically, does not always get the attention that it really requires. Okay, so the suicide rate is increasing across the country. And this diagram from the CDC is really showing the, the increases in most of the states across the country, and then the factor in which it's increasing. And you can see that, generally we've got a lot of kind of the Midwestern states and more, some of the more rural states actually having larger increases. And suicide is a leading cause of death across age categories. And so for all ages, we say, you could see on the bottom right, it's the 10th leading cause of death. When you look at young people, it's the second leading cause of death, so between ages 10 to 34. And then you can see it kind of decreasing a bit. But this is, we do focus in a lot on young people and risk of suicide because it is a serious concern, being the second leading cause of death. So in the next few slides, I'm just going to go over what, suicide, how suicide is impacting by different demographic groups. It's really important to kind of get an idea. There are similarities between those who are impacted by overdose, an overdose death, and suicide, but there are also some differences. So you can see that there are differences by age, differences gender and race and so forth. So I just want to take a few minutes to go over this. And then you also get an idea too that interventions are requires kind of like a whole spectrum of interventions for suicide prevention because each community is impacted differently. So when you're looking at by age, you see that there's kind of an increase up to middle age, a slight plateau, and then it increases again as you get to 85 and above. And we talk in the suicide prevention field about middle age being high risk. And then we also talk about older adults being at high risk, and there's a number of reasons for older adults, one being isolation. You're also, retired, you don't have the same, social network, both either professionally or personally, because a lot of times that social network, members of that social network and loved ones have passed away. Also, there is, a certain level of frailty in that in an attempt, it's more likely to end in death because, the body doesn't, isn't as resilient as it is with a young person. And then also having access to prescription medications. And then important to note also, we look at trends. And I said at the beginning that we're seeing an increase in suicide, kind of a steady increase over the years. If you look closely here, we're talking about, on the left, I was talking about middle age being high risk. We see the middle age line, that green line on the top, towering above the others. But you also see that it's kind of flattening off in recent years. Then when you look at the younger population, you see that of course it's lower, but it's increasing. So sometimes you have to look at the data a couple different ways, otherwise you're kind of hiding some of where the issues lie. So I just wanted to, as I said, sometimes it hides where the issue is lying. I just wanted to look at this a slightly different way. And you can see again, so we have the yellow line is the middle age, and then we're looking at the young people at the blue, 10 to 24. You see the huge increase, and this is for percent change. And you can see kind of the decrease. And looking at it since and more recent, since 2010, you see the increase of the blue line. It's pretty much the yellow line is staying close to 0%. So the if you're kind of reading in the newspapers and online about different trends in suicide, every now and then you'll see an article about suicide among youth and how that's increasing, and that's really kind of what's in at the top of the forefront of everyone's mind in the suicide prevention field and suicide prevention professionals. Now, looking at this by gender, I think, a lot of us know that males are disproportionately impacted by suicide. They make up over 3/4 of the suicides. Females, it is much smaller. And then we look at this by gender and age. We again see the rates towering, for males above females, and you see the same increase into middle age. But as far as the older adults go, you see a large increase as you're getting to, the oldest age category. But you do not see the same thing for females. So, we asked the question about, what makes the difference here between men and women, and one of them is the means, the method of suicide. And we know that firearms are the most lethal method of suicide. And so it just in general in the US, firearms make up about half of suicides, followed by suffocation and poisoning. And then you can see when you break it down by gender, you have over half are by firearm, where it's only about 30% for females. Suffocation is about equal, but poisoning is much larger among females. So we're talking about like drug overdose, which drug overdose is the least lethal means. And this is a busy slide, but there's really not, not a better way to present it. But it is important to look at racial ethnic differences for suicide. And and this is by age. And we talk a lot about, as I said, middle-aged, but then we talk about white middle-aged men. So that's a very high-risk category, is white middle-aged men. And you can see that, the dark blue line that towers up in the middle there, that is white middle-aged men. The other category to look at here is American Indian, Alaska Native. That's a very high-risk population as well. And we see that the highest rates are among the young people in this category, and then it tends to decrease. So those, pointing out the highest risk, but then there are other specific risk areas among other groups as well, which I'm going to get into momentarily. Maybe I did not include that slide, but another issue, so if you've been kind of reading closely into the news that's come out, and we talk about youth suicide, there's also been a special focus on Black youth, and particularly very young, like 5 to 11. And there's been a couple of articles to come out on this, but pretty much it ends by saying more research is needed to find out, really to understand reasons for this. And the reasons that we kind of land on is access to care, and there's a lot of stigma in communities, as well as just not having the same access to behavioral health care. Another key element here is the being in the rural area is a huge risk factor. And you can see, we see in this this graph, there's just a general increase over the years, but also the more rural you are, the more rural the area you live in, the higher rate of suicide. So as you see, like going from large central metro to non-core, that's the non-core is the most rural for classification, and you can see the highest rate. And there are multiple reasons for this high rate. One of them is just high rates of gun ownership. And then there's also lack of access to services, long distances to get to services, lack of transportation. There's stigma involved, particularly because you pretty much, a lot of times if you go into to get services, other people will know. They could be working in the place where you're getting services, or just know because there's sometimes a lack of privacy. And then there's also kind of the feeling, the culture of self-determination, and feeling like you really want to handle these issues on your own. You don't need to get help for them. And then, as I touched upon, you can look at like methods of suicide in rural versus non-rural areas, and we see, not only is just generally the suicide rate higher, but the suicide by firearm is much higher. And you can see that it was about half in the U.S. in general of the suicides that were by firearm, and we see in rural areas it's up to 60%. And then, when we look at suicide as a public health problem, it's much, suicide in general it's relatively rare. And when you're looking at other things, numbers are low, but we look at the larger picture, there are people who attempt suicide, but who do not die by suicide, and there are major consequences and major health impact to that. And then there are people who are thinking about suicide, who don't, ever act on it. That's very difficult for these people to be dealing with constantly, as well as, family. And then there are people who lose loved ones to suicide. So there's just an exponential impact. And we can see here, we talked about young people and women being less impacted than middle-aged, older adults and men. But in terms of self-harm, which is the best indicator we have for suicide attempt, we see young people have the highest rates by far. And a lot of young people will use less lethal means, and they're very resilient being young and can recover from an attempt. And then females we talked about before, using less lethal means as well. And then in the bottom right corner, it's just important to point out that there are 25 attempts for every death. And then for youth, it's estimated that there are 100 or 200 attempts for every one death by youth. And then it's only 4 to 1 for older adults. Again, kind of what I was saying before in terms of the lethality also mixed in with frailty at that stage of life. And then, for each suicide, there are approximately 147 people exposed, meaning impacted by that suicide. And if you have time later, you might want to take a look at that source link that I have there from the American Association of Suicidology. Every year they put out a data packet that has information like this, very useful information. And it also has state rankings for suicide, and that's very useful if you're at all interested in applying for funding from any source. It's helpful to see the number of suicide, the rate of suicide, and how it ranks with the national average, as well as just in general with other states across the country. And then the other data source here that we can look, get more of an idea of, the story with youth is the CDC's Youth Risk Behavior Survey. And they ask a few questions about, sadness, hopelessness, as well as thoughts of suicide, making a plan for suicide and attempting suicide. We can see, females have higher rates or higher percentages of all of these. But we see just generally, when we look at the total, we have almost a third saying that they have felt sad or hopeless in the year prior to the survey. Almost 20% saying they've seriously considered attempting suicide. About 14% have actually made a plan, and 7% reported a suicide attempt. And then another very high risk group is the LGBTQ group. And you can see here, it really points out the light green, how much larger the percentage reporting feeling sad or hopeless, over half. We have almost half reporting seriously considering attempting suicide. About a third have made a plan, and we have almost 20% saying that they've attempted suicide in the year prior to the survey. so this is, a high risk group that we have been, trying to target in my work, and it's they also, this group also has, high risk for substance use and substance use disorder as well. So now I'm just going to go briefly into the intersection of substance use and suicide, give a little, better picture of this. And we can see, I'm bringing back this graph that I showed at the beginning, and just have one additional line. It's that line towering above everything else, and it's drug overdose. So we see, I mean, we're all familiar that we're, in an opioid epidemic, and there's been just a very large rise in deaths by opioids, and it really towers over that orange line for suicide. So the increase in suicide has really been a steady rise, along with that huge rise among opioid overdose deaths. And I always, when I'm giving this presentation, tend to say something that I'm already going to say in the next few slides, so I will hold back on that. But we know that these are both major public health problems. And then here we can, this is just another way of showing that this is the actual age-adjusted rate per 100,000 rather than percent change. And we just see that, both suicide and drug overdose have been increasing. It's been a little bit of a slower rise for suicide, and just a few years ago, the rate of drug overdose, unintentional drug overdose, surpassed that of suicide. And then some of you may be familiar with the term deaths of despair from a Case and Deaton article from 2015. And we know that the main focus of this article was talking about how those white non-Hispanic individuals in the 50 to 54 age category, or middle age, were really experiencing deaths of despair, so deaths by suicide, drug overdose, and alcohol poisoning. That they were really, the deaths for those reasons were so high that it was really increasing all-cause mortality, really overturning that trend. And one of the major, risk areas were those who had a high school education or less. So you can see that, red line both for drug and alcohol poisoning as well as suicide towering above the rest. And then this is, unique in the United States compared to other developed countries too. So we're seeing this increase where other countries are, for the most part, seeing a decrease. So future Case and Deaton did come out with an article a couple years later that followed and showed that this is really not just an issue in middle age, it's an issue across the age groups. And it's really just the understanding that there are some economic issues, and individuals are seeing that they thought that they would be better off than kind of generations before them, or their parents' generation, but they're seeing that they're not. And a lot of this is, as I was focusing in on rural areas, there's a lot of focus there, for example, with struggling farms and businesses. So this, combining substance use, drug overdose, alcohol poisoning, and suicide just creates a major storm. So substance misuse and suicide, they're closely linked. And we're talking about the impact of opioid overdose and the opioid epidemic. So the suicide rate among those with opioid use disorder is 6 times the rate of the general population. So if we're talking about a rate of 14 per 100,000 for suicide just in general in the US, the rate for those with opioid use disorder is 87 per 100,000 population. And then those who misuse opioids, they're much more likely to have thoughts of suicide, so between 40 and 60% more likely. And then those who regularly use opioids, they're 75% more likely to have made suicide plans and twice as likely to have made a suicide attempt. So we see that this just puts, vastly increases the risk. And then we're looking at suicides, after a death during an investigation, and we see that 20% of suicides in the U.S. involve opiates. And then, so the key point here, when we look at the suicide as a public health problem, we see that it's been steadily increasing, and that's with the data that we have. So we know that research has shown, and we know in the suicide prevention field, that it's very difficult to be able to firmly to confirm that a death is by suicide. So the research shows that 20 to 30% of overdose deaths, so those are termed unintentional, are actually intentional, so they're actually suicides. It's really hard to determine intent in the absence of a suicide note. So for the most part, a lot of the ones that are actually deemed a suicide are accompanied by a note. So there's also, first of all, with all of that in mind, we can say, what, the suicide rate is probably higher than the data is actually showing. The other thing is that many overdoses are among individuals, they don't have an explicit intent to die, but it might really just be that they don't care about the risks. So I've had conversations with directors of addiction treatment centers, and just kind of in general with clinicians, and I've heard it expressed that a lot of times patients with substance use disorders, they just don't really care. They don't say that they want to kill themselves, or they're thinking about suicide, but they don't really care about the risks. So they know, and we know particularly now with fentanyl, we don't really know necessarily what's in it and how lethal it is, and it could be any time you take it that it could be lethal. But they know that and don't necessarily care. So in a way, that's suicidal behavior in and of itself. And then last here, we also know that we're talking about alcohol intoxication. So up to 40% of both lethal and non-lethal attempts involve alcohol intoxication as well. So there are definitely a few different factors that can go into this connection. And one of them is that individuals with substance use disorders are twice as likely to have mood or anxiety disorders as well. And those, mood and anxiety disorders are also linked to suicide. Depression is the most common risk factor for suicide. And we say that substance misuse is the second most common risk factor. A half of individuals with mental illness will also have an SUD in their lifetime. And then, so chronic pain sufferers are also a very high risk population. They are prescribed opioids, and they also may have comorbid depression, particularly when struggling with pain that is chronic, and there's really they're just trying to manage the pain. And then during intoxication, there's tends to be disinhibition. So things that you'd normally wouldn't do, or you would find alternative coping strategies, don't necessarily come into effect in this case. Using alcohol increases depressed mood, and then it also can increase proximal risk, so like aggressive behavior, constricting cognition, so maybe not being able to generate or implement alternative coping strategies. So a lot of times, suicidal thoughts, there are urges and they come and go, but when it comes and you can't really have the ability to generate another coping strategy, it can be, the time from a thought of suicide to actual action can be very quick. So another reason why this is, the use of alcohol can be very problematic and very risky. So, with all of this in mind, we say, it's very important to jointly address substance use and suicide. So are, some of the major, institutions that deal with both of these issues. One of them being SAMHSA, another one, the Trust for America's Health. So I have the links here if you want to read more about these reports. SAMHSA a few years ago put out this kind of guide, a brief for how how the two issues intersect, and then how you can work on jointly addressing them. And then Trust for America's Health put out actually a number of reports. This one particular here is focusing on adolescent substance use and suicide, but you can access a number of different reports. The term self-injury mortality I find to be very important, because we talk about how closely these two issues are linked, and even not knowing whether a suicide is or whether an overdose is actually a suicide or not. Looking at self-injury mortality, if we're combining deaths by overdose and deaths by suicide, that's a very large number, and it's a very compelling case for the importance of focusing public health funds to address these issues. And the other thing too is that we're trying to fight this opioid epidemic, and the issue is that we've got kind of this multi-pronged approach to do this. But one of the elements that may be missing is that suicide prevention could actually be opioid overdose prevention and substance use prevention. So there are definitely, we're talking about there being kind of thoughts, not necessarily active thoughts of suicide, but more of like not caring about the risks. There are some elements of suicide prevention that may be able to effectively address that. Understanding how these issues intersect, starting about a year ago, actually. Accreditation groups have started to put in minimum required standards for suicide care and addiction treatment. So one of them is CARF here, and then there are actually a couple of other ones as well. So this is really important in kind of moving the needle to getting substance use disorder treatment to really address suicide risk. And kind of the data that I was just walking through really highlights the importance of having these services available among this high-risk population. And for those in treatment, that's a captive audience right there to be able to deliver these services, which I will be getting into shortly. So I'm going to begin. It's not the major portion of the presentation, but I am going to talk a bit about prevention in communities, as I do come from a public health background. So I always have to kind of put in the plug for more upstream community-based intervention, because we're not always, we don't always have access to the individuals they have to be in treatment or seeking health care in order to be able to provide it in that setting. So first is, we talk about community awareness. So the awareness of suicide and how to talk about suicide. There are definitely a bunch of campaigns out there available for use, and it's the same with substance use, and to be aware of the intersection. And then there are ways of getting help that are easily accessible. So we talk about access to care. We have services available, at our fingertips that we're mostly not aware of, that are available 24/7 and are really with trained providers. So one of them, so we talked about hotlines like the National Suicide Prevention Lifeline, and then there's crisis text lines. So now we know that a lot of people prefer, particularly young people, to text rather than to call. And you can also kind of do other things while you're texting. People find it very convenient. I've actually talked about crisis text line with college students, and have heard that about crisis text line. So crisis text line provides services for not just people thinking about suicide, but for people to talk about substance use issues. It's about relationship issues, depression, anxiety, domestic violence, school issues. So that's available, and there's a lot of states have promotional materials to get the word out about crisis text. And there's also actually a lot of states have specific keywords so that they can track usage and really try to better promote use of these services. And I'll get into it a little bit later, but there's you can just in general text the word start to 741-741 to speak to a trained counselor 24/7. Then there are multiple trainings available for different audiences. And we talked about in the suicide prevention field about gatekeepers. So gatekeepers are those people who come into regular contact with people who could be at risk. So they're like, the kind of strategic people to be training. So there are different trainings available for community members. They range from like an hour-long training, for example, question, persuade, refer, or referred to as QPR, an hour-long. It raises awareness and about how to talk about suicide, how to get someone to, to find out if someone's thinking about suicide, to persuade them to get help, and then refer them to appropriate services. There's also kind of a half-day training called Safe Talk, and then a 2-day more intensive training called Assist. Applied suicide intervention skills training. So that's ASIST rather than the typical what we think of assist as a substance use screening tool. And this 2 days like a brief intervention training that really provides the individual skills above and beyond the other 2 trainings, and how to keep someone safe in a crisis and how to get them to the help that they need. And then, schools, there are a bunch of school staff have been trained in those types of trainings, but there are also school-specific trainings as well that range for, again, like more kind of awareness and referral trainings for teachers and other school staff, all the way to kind of a more like workshop, like a full-day workshop for administrators on how to develop policies and procedures, and then those for student support personnel and psychologists and social workers within the school, and how to actually provide services for youth who are identified as at risk. And then there's also postvention, which is what to do in the aftermath of a suicide. So we say that postvention is also prevention, because there can be deaths, negative consequences following a suicide, such as suicide contagion, and you want to really avoid that. So it's following a suicide, if there are really no plans in place, emotions get involved and you might not follow the appropriate steps. So it's important to have kind of a standard set of operating procedures in advance, so that in case there is a suicide, that the steps take, who's going to be involved, how to work with the media so that it's, if any news comes out of this, that it's reported appropriately, and how to kind of provide services to the community that are impacted, and having a team available as well that's part of this, that is a small team, so that how to act in this situation. And then having access and using data to inform local efforts is critical at the community level, because it really informs you can't just kind of take national data and use that to a local area. And the other issue too is that there's a data lag. I mean, we don't get the data that we look at is at least 2 years old, so we don't have access to timely data, which isn't unfortunately not actionable. So we try to come up with ways to increase, to have quicker access to it. So for example, some coalitions in counties have medical examiners or coroners, so they can get quicker access to local data. A couple of states are working on setting up a model where can collect more comprehensive data, have it available in real time, and then review cases with key stakeholders in the community, and to really come up with ways to what were the issues involved, and then provide really identify touch points for intervention. so this is a relatively new model that's getting increased traction. And then we also we actually set up in New York State a data dashboard that has county level data too, so it's very easy to access and understand. Linkages to care is critical too, so it's important to know that if someone is identified as at risk in the community, how to get access to behavioral health care and to care where where providers are actually trained in suicide safer care. And then collaboration between community coalitions and task forces. So to know in your community which coalitions and task forces that are present. And we have suicide prevention. There are a bunch of suicide prevention coalitions and substance use and opioid task forces. And to know that, so a lot of the times it's the same person on both of those. The same people on both of those committees or coalitions, but there are different people and there are such similarities between the issues, and we were talking about how they intersect, that if there is collaboration, then there can really be joint traction being made. And the last thing is that I want to talk about is like the local health and mental hygiene directors, to really bringing them into this. So typically in some states where they have mental hygiene directors, they're the ones that are overseeing the behavioral health efforts. A lot of them are pretty aware of these two issues and what the best practices are, often sitting on these coalitions or task forces, but sometimes not. So having them their key points of education and instruction and guidance. Local health departments as well, should be involved in this. Some counties they are, some counties they aren't. So I think getting them involved as well is critical. So kind of touching on the last two bullets that I brought up, last year we did this study, we call it a community collaboration study. And this, we're working on getting this published. So far it's unpublished. So this will be, one of the first times we present this information publicly. So this survey, we were really trying to, our goal was to figure out how to create opportunities for community level collaboration among key New York State stakeholders. So we had this survey, we were exploring attitudes and perceptions regarding suicide and overdose, identifying facilitators and barriers to collaboration, assessing current practices for suicide prevention, and identifying populations and areas of need. So this was done through SurveyMonkey. We distributed not only to the leads of substance use and suicide prevention coalitions, but also to these what we call directors of community services, which are essentially the local mental hygiene directors in New York State. So we received 54% response rates. We were looking to, we had a total kind of end of like about 300. So we received 160 responses. So, we were not surprised that respondents, agreed that suicide and opioid overdose are problems for their counties. But of course, also we weren't surprised that few believe their counties have the necessary funding to prevent these deaths. So, one of our goals here was really to figure out that we needed some information because we do want these counties to have funding to address this. So, we see very few thought that they had the funding they needed. We do see that substance use coalitions did feel that less of them, so only about 3/4 thought that suicide was a problem for their county. So I think here we see maybe a little bit of education would kind of raise the suicide as a public health problem for this group. And then we see definitely they see the value of collaborating. So interesting here, so that we asked them what the populations are most in need of suicide prevention. And you look at the data here, so we have people with risky substance use, 3/4 of respondents said that this population was most in need of suicide prevention. But we say, this is among a group of substance use prevention coalition leads. But when we broke it down by, the one group, substance use prevention coalition leads, and then suicide prevention coalition leads, and then those directors and community services, all three of those groups separately also said that persons with risky substance use were the population most in need. And you can see closely followed by adolescents, young adults, and then men in middle years, veterans, and LGBTQ+. Familiarity of prevention practices. So this was important, and we, interestingly enough, so that I think one of the key takeaway points here is that for the most part, directors of community services were, most aware of some of these practices, more aware than the coalition lead, so they can definitely provide education and guidance to these groups. But interestingly enough, like, substance use coalitions were kind of less familiar with SBIRT than even the suicide prevention coalitions. And they're not, you can see, not as aware of validated suicide risk screenings, of crisis texts, brief interventions for individuals at risk of suicide, even the National Suicide Prevention Lifeline, and then Postvention. And you can see how much lower it is for Postvention, and this is critical, which I am going to address much later in the presentation, about the importance of Postvention for opioid overdose death as well as suicide. So what were the opportunities that we identified in the survey? One of them was distributing materials on the respective trainings that are available. So almost 90% said that they would like to do that. And about 80% said they would like to combine short trainings, such as like a training in the administration of naloxone, along with QPR training, which was that hour-long presentation that in training that I just mentioned a few minutes ago. 3/4 said educating substance use providers on the importance of suicide safer care protocols, and then about 80% wanted to participate in the joint learning collaborative. So all of these, are very actionable for us in New York State. So what were the facilitators and barriers? So clearly facilitators would be to have appropriate funding, and then also having improved data collection. So data collection is definitely would be very useful, having timely, actionable, comprehensive, and complete data. And that's something that we are working on, and that states across the country are struggling with. And barriers would be lack of staff time. These coalitions don't often have dedicated staff time, and then scope of work limitations. So we talk about having a substance use prevention coalition and a suicide prevention coalition. The scope of work, a lot of times for the substance use coalitions, because they have, at least in New York State, they're funded by SAMHSA, so they have to address substance use, and sometimes if you delve into suicide prevention, no matter how much we say that they intersect, sometimes that goes out of the scope of work. So this study for us helped us to identify different areas that we could provide education, training, and technical assistance. Clearly presenting how suicide prevention is a key element of opioid overdose prevention. Free resources, 24/7 resources. So not only what I had mentioned, the Suicide Prevention Lifeline and Crisis Text Line, there's also in New York State a Hope Line, which helps with, provides support for addiction in New York State. And then best practices for addressing specific populations identified in the survey, then how to strategically braid funding. So I'm going to delve into suicide prevention in healthcare settings now. So this is going to include, all the way from population-based primary care to specialized behavioral health settings. And I'm going to begin by just talking about, I'm going to just briefly present another study that we conducted recently to talk about training. And one of the things that we know that when I went into the suicide prevention field, because I came from the substance use prevention field right to the suicide prevention field, I was surprised that mental health providers weren't trained in suicide prevention. A lot of them don't have that training. So, we wanted to know if substance use disorder treatment providers had that training, or was it the same level of training that they didn't have, like mental health providers, or were they even less prepared to treat individuals who might be at risk for suicide? So, training is a key, kind of thing that we struggle with. And, so we wanted to find out a little bit more about what the needs were for substance use disorder treatment providers. So we distributed an electronic survey again to 9 large health systems across New York State, and we were really looking at beliefs about suicide, perceived self-efficacy, perceived effectiveness in working with suicidal clients, and frequency of suicide prevention practices. So this was done between November 2018 and January of 2019. So we had a 64% participation rate in this survey. We had fewer substance use disorder treatment providers in general, so we had 153 responses there. So among substance use disorder treatment providers, so they are seeing clients who died by suicide. So about a third have worked with clients who died by suicide, and about 80% have worked with clients who attempted suicide. So we know that it is a problem among their patients, and very important that they provide these services. So self-efficacy. So we see that the ones with the asterisks shows that that the substance use disorder treatment providers had significantly lower scores here than mental health providers. So they were, this is the percent that strongly agree that they feel confident in their ability to do these following things. So screening clients for suicide risk, we had less than half felt that they felt confident in that, and that was significantly lower than mental health providers. Conducting a comprehensive suicide risk assessment, managing clients' suicidal thoughts or behaviors and treatment, developing a collaborative multi-step Stanley Brown safety plan. That's a best practice, and we only had about a quarter saying that they felt confident doing that. And then conducting structured phone follow-up with clients in the days after discharge. So these are critical elements of what we would say are best practices in suicide prevention. So when do substance use disorder treatment providers do the following items here? So these are, again, kind of best practices, and screening here is to screen at every visit with all clients. We have very few. We have about 6% doing that. At every visit with clients at elevated risk for suicide, we have 60% reporting doing that. When a client's record indicates any history of suicidal thoughts or behaviors, we have about 72% saying that they do that. And whenever I suspect a client may be at elevated risk, we have 82%, and then with all new clients, 77%. So we see some of them. This to me kind of pops out as being as troubling, because we see that when someone suspects that a client may be at elevated risk, we don't see 100% doing screening here. When a client's record indicates history of suicidal thoughts and behaviors, we're only seeing about 70%. So we need to see a much higher percentage than that. And then all new clients, really, we talk about the risk of suicide for those with substance use disorders. It really, all new clients should be screened. And then we asked about practice frequency, from 1 being never to 5 being always. How often are these practices performed? And we see a lot of, none of these are really quite touching on the 4, saying often. So it's about, sometimes these things. And these are things that kind of need to be done routinely. This again shows that the current practice among at least the SUD providers that we surveyed is not where we were hoping it would be. So we know that this is, it's very important to provide STD treatment, but also required for accreditation now, like I was talking about earlier. So providers are seeing patients at high risk, but they're not confident in their ability to provide suicide safer care, and also not routinely providing best practices. So we really suggest, the areas of education and training for the substance use disorder workforce. So, with that in mind, I kind of touched upon, what the practices are, and the self-efficacy on different best practices in suicide prevention, and the information, education, and training is required. So what is that? What am I talking about? So I'm going to get into that now. So the zero suicide model kind of is something that we follow in the suicide prevention field, and it's a set of we talk about zero suicide. It's really an aspirational goal. We can't ever say that there are going to be zero suicides, but it's also, a set of tools and resources to help implement these services. So there are 7 domains: lead, train, identify, engage, treat, transition, and improve. And this can be conducted in all different types of healthcare settings: primary care, emergency departments, hospitals, inpatient, outpatient mental health, and of course, substance use disorder treatment clinics. And it can also be conducted in school-based health centers and college health centers. So what I'm going to go through is also, it's not just for adults, it's for adolescents as well. So what I'm going to be, the lead element that I just mentioned is more about like kind of getting organizational buy-in, and kind of showing that this is a team effort. It's not on the shoulders of one individual person. But I'm mostly going to focus here on kind of what the steps are here in the clinical protocol. So this is something that, so I'm bringing in the kind of a pre-screen, the PHQ-3, which is part of the PHQ-9. And in the substance use prevention field, when we try to pull in kind of, mental health, we tend to talk about the PHQ-2. So the difference here is that the PHQ-3 brings in that last question, the number 9, which is thoughts that you would be better off dead or hurting yourself in some way. So this would trigger, if answering question 3, that they said they do have these thoughts, it would trigger an additional screening question, so the CSSRS or the ASQ. And this would be done more in kind of a population health setting. It could be done in substance use disorder treatment, but I think it's really important to conduct kind of a full suicide risk screen in this setting due to the high risk. So that is, where I'm going to talk about this. We call it the Columbia screen, or the Columbia Suicide Severity Rating Scale. And this, it's critical because, when we have one question asking about, a wish to be dead, that's passive suicidal ideation. We need a lot more information than that to really know what the risk is, because our goal is to keep the client in the least restrictive environment. We do not want to act like there is much more risk than there actually is, and then hospitalize someone, or have the cops come and pick them up. It really creates a situation where they probably won't want to be honest if they're having these feelings again, and won't share it because they are afraid of the consequences. So this provides a lot more information about risk, passive ideation, active ideation, and presence of a method, plan, or intent to actually act on thoughts. So the first 2 questions, all items are yes or no, and the first 2 questions assess general ideation. So the first question is passive ideation, or the wish to be dead, and the second question is active ideation. So what you're really saying, having thoughts of actually killing oneself. And if there's a yes response to any of these questions, it triggers the remaining questions. If there's not a yes response to those, you'll still ask the last question, which is about suicidal behavior. So the other questions assess the presence of a plan, intent upon acting on thoughts, having both a plan and intent on carrying out the plan, and then actual suicidal behavior, both lifetime and recent. So these are the questions right here. So, the first question is about, and this can be used for both adolescents and adults. So this first question is, have you wished you were dead or wished you could go to sleep and not wake up? So this is what we call passive ideation. So it's just a wish to be dead. Have you actually had any thoughts about killing yourself? So that's an active ideation. So as I was saying, if it's a yes to those, you answer the questions 3, 4, 5, and 6. If no, you go directly to 6. So have you thought about how you might do this? So this is asking about whether there's a method. And then 4, have you had any intention of acting on these thoughts of killing yourself, as opposed to you have the thoughts, but you definitely would not act on them. So this is getting at intent. So you see question 3 is in that kind of orange, like moderate risk. And question 4 puts an individual into high risk, having an intent to act upon something. Question 5 is, have you ever started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? So this is asking whether there's a plan plus intent to act upon that plan. So that again puts you at even higher risk. So, when we talk about positive scores here, we kind of put 3 as that gray area, 4, 5, a yes to 4, 5, and 6, that is a positive screen. 3 is a moderate risk. And then question 6, have you done anything, started to do anything, or prepared to do anything to end your life? So they provide some examples here about what that means as well. In fact, this is the highest risk category, someone that's engaged in behavior. So interpreting this, the low risk, so those yellow boxes up top on the previous slide, that really indicates the need for a behavioral health referral. Question 3 about the thought with method but without a specific plan or intent is puts you at that that orange box, the moderate risk. So it kind of indicates a need for a behavioral health consult with a social worker or a psychiatric nurse, and then to give some thought to patient safety precautions. But after you get to that, the rest is high risk. And we're talking about having the consultation and definitely putting into place patient safety precautions. So I'm going to just show you this quickly and then talk kind of what the services that would and interventions that would be provided following the screen. So just briefly, because I know there are some adolescent-specific providers on this webinar, that this was designed to be used with adolescents. This is the Ask Suicide Screening Questions tool. So you can see the language is a little simpler, and it does get at the same information. It's just asked in a different way. So you can access this screening tool at this link. And then, so it also provides you kind of with the next steps, pretty clearly how to react based on the questions and the responses. And then key here, you can see kind of in the middle here, provide resources to all patients. So something we like to call universal precautions. So we say that if someone screens negative, we don't, that's not it. We like to use the opportunity to provide information and resources. So here they're saying to provide the number to the National Suicide Prevention Lifeline and the crisis text line. So here you can see there are many different words that you can text to 741 741 to reach crisis text line. So here they have home. In New York State, we have a keyword GOT5, GOT5. You can also text start 741 741. So this is really the idea that someone might not have suicidal thoughts right now, or any, but if those, or even like kind of risk factors for it, that there are resources that are available if it does come up that you can use. So what do you do after a screening? So if there's imminent risk, of course, you need to do what needs to be done to keep a client safe. It can be, an emergency evaluation. It can be hospitalization, but those not at imminent risk. So the tool will tell you when someone is at imminent risk, and you can also use clinical judgment there. But for those not at imminent risk, you review the crisis information with them. So, of course, the local and national crisis hotlines, clinic hours, after hours, emergency numbers, local services such as the emergency departments or psychiatric emergency departments, developing a treatment plan that addresses suicidality directly, reduces risk factors, and improves protective factors. So what we know in the suicide prevention field is that there are definitely risk factors and underlying conditions that lead to thoughts of suicide, like depression, like substance use, but we can't just focus on those and hope that the suicidality goes away. A lot of times it takes too long, and suicidal thoughts and urges, they come and go very quickly, and there's a lot of times a very small amount of time between the thought and the action. So we can't just focus in on, addressing the substance use or addressing the depression, that there are treatments specifically addressing suicidality. We also need to increase clinical contact, follow up and monitoring between sessions, and conduct a safety planning intervention before the end of the risk assessment session. So we're saying kind of to have that available following the assessment. So what is the safety planning intervention? So this is, we know that the term safety plan can be used in so many different ways. In the substance use disorder treatment can be called relapse prevention plans, crisis plans. This is different. So the idea is that this plan is to help an individual who has thoughts of suicide to make it through a time-limited suicidal crisis. So this would not apply to someone who is experiencing, who's not experiencing a suicidal crisis. So this can't really be put in place for anyone just in case something, that these thoughts do come, because it needs to be sensitive and specific to a certain situation. Otherwise, it would really just be a form to complete. And this is not just a form, this is a collaborative intervention with the trained provider. So like I'm saying here at the bottom, having an overly general crisis plan is not going to be helpful. Because it's just not going to be, like, for example, like triggers and coping strategies for other issues like substance use or domestic violence are not going to be the same as those for suicidal thoughts. So the idea, I've said that suicide risk fluctuates over time. So this plan provides an individual the ability to deal with this fluctuation and these urges in the community on their own. And it really helps with coping and problem solving, and it provides them the self-efficacy to remain in the community and to be able to live, a productive life as they go through and get treatment for these issues. So it's the idea that it's done collaboratively with the trained provider, and you're looking for both cognitive and behavioral strategies to use during these crises. And it's directed by the patient to really generate their own ideas. And this is evidence-based too, and we can see that there's a positive impact for those who receive safety planning intervention. Not just for suicidal behavior, but also for attending outpatient treatment following this intervention. So the 6 steps, they're kind of sequential, that you identify warning signs first. So this is individual warning signs when an urge comes. Internal coping strategies. This is really not contacting another person. This is on your own. So for example, going for a walk or listening to music. Socializing is the 3rd one. So this is really identifying people that you could call to distract you, to talk about something or do something that where you do not bring up the issues that you're having and the thoughts that you're having. The next, so pretty much each step, so if the internal coping strategy doesn't work, then you go to the socializing step. And if that doesn't work and you're still having these thoughts, you would then list, and so when you develop the plan, you list, but then you would contact family members or friends you've listed here to help you resolve this crisis. If that doesn't work, you then you look at the numbers on your plan that you put down that you can contact. These are mental health professionals or agencies or even your primary care provider or the crisis text line or the National Suicide Prevention Lifeline or any local hotline that you would use. And the last step is making the environment safe, so reducing access to lethal means. So for example, if there are prescription medications in the house, or you own a firearm, that you would then make sure that those are away from you. You give them to someone else or lock them and put it somewhere where you cannot access it in this time. So this is done as a brief intervention. And so what I'm going to do, I have some examples here about what you would say as you being a clinician going with working with your client on how to develop the safety plan. I'm not going to go through all of it, but the idea here is that you want to get the elicit the information from the patient and have this all written down, and then so they can leave the office with it and be able to use it. So whether it be on paper or in an app. And then if any doubt is expressed, you want to make sure that you kind of assess what those kind of doubts are, what the barriers are, and if these would really work in those situations, and make sure you develop something collaboratively that would really kind of address the situation that they're in. So like I was talking about apps, there's some apps that are available. The My3 app, I think, is probably the most well-used one. And then there's also the Stanley Brown Safety Plan app. So, clients can just enter what's discussed and come up with on the safety plan right into their phones. And everyone, pretty much has their phone on them all the time. And so they have this safety plan available whenever they need it. So another element too, so the highest risk time for someone who has thoughts of suicide is the 72 hours following discharge. And that would be same kind of for substance use disorder, inpatient substance use disorder treatment patients. So the idea of providing follow-up and monitoring through structured phone follow-up. It's not just a phone call, but there's a specific structure and plan for it. Where you would, so these trained clinicians would assess mood and current risk. So you can actually administer the Columbia screen again since last visit to determine level of risk, and then to contact a crisis line if imminent risk is detected. And then it's important to review and revise the safety plan. So again, it's a living document, and see what worked and what didn't work. Removing unhelpful items, identifying more helpful ones to make sure it's kind of the best plan in place. And then reviewing access to lethal means. So is there a need to remove or kind of lock up any lethal means that are available to the client? And then really assessing treatment, engagement, and motivation. So what is the treatment plan? Let's review the treatment plan, problem solve any obstacles to receiving treatment and completing treatment, and provide any information, again, on available community supports. And important too is to follow up more than once too, and to obtain consent and willingness, and also to set up a time, so to make sure that you can actually reach the client. And critical is to let them know that how, if they need to, how can they initiate future care if they need to. So follow-up monitoring and referral. Something very simple for practices to do is the non-demand care and contact. And you can see kind of on that second bullet that there's research, very clear research that shows the impact of this. And what it really is providing, postcards or, letters, emails, text messages now. It just contains a brief expression of caring. So it's, a lot less demanding than that structured phone follow-up. It's simply saying, it's been a while since we've seen you, and if, we're, we, value you, and if you have any concerns or questions or like to contact us, here's our information. Something very simple, and just doing that has had such a positive outcome. For based on the cost, it's such an intervention that practices really like to pick up. And then it's important to do a warm handoff to other levels of care. And there are other suicide-specific treatments that I didn't really get into, but this is for those strict kind of mental health providers to provide cognitive behavioral therapy. There's a specific one for suicide prevention, dialectical behavioral therapy, and then collaborative assessment and management of suicidality. And then, so postvention that I touched upon earlier, it's really important. So there's postvention in communities, but then there's also postvention for clinicians who lose patients to suicide. And I've done some work as well to kind of, expand that to patients, to clinicians who've lost patients to overdose. And so, most clinicians, as I was talking about earlier, in the behavioral health field have lost patients to suicide. And as a result, half in this study in 2018 showed that they changed their practice patterns as a result of losing a patient to suicide, asking for increased supervision, using formal measures to assess suicidal thoughts and behavior. But few actually began using a formal postvention protocol or toolkit. And though it's not a lot, 10% actually stopped accepting patients that they deemed at risk of suicide. So we know that postvention is rare, it's variable and underutilized, but losing a patient to both suicide and losing patients in general, but to overdose and suicide, it's increases, it's a major burden, and it increases risk of burnout. So we know that there's, of course, a lack of standardized approach and training and preparation in this. So this last bullet I provided a link. There's not a lot of information here, but the American Association of Suicidology has a clinician survivor task force with a lot of useful information that you can access at that link. And also in New York State, our mental health agency worked with our substance use prevention and treatment agency to develop a training, both kind of a general training and a train the trainer, so specifically for clinicians and health systems to provide postvention for patients, or for clinicians who've lost patients to both suicide and overdose. This was, so important to the state because, with the opioid epidemic and the steady rise of suicide, there's a lot of staff turnover as a result of really not being able to manage this burden and this burnout. So this is, it really, it's not something that it's like the first thing we think about when we try to work on these two major public health problems, but it's definitely critical to know how to work with clinicians when they have lost patients. So the last thing I'm going to touch upon here is suicide prevention and the SBIRT model. So I know that a lot of you are familiar with SBIRT, just kind of knowing the audience here. So I'm going to go over this, but so screening, brief intervention, and referral to treatment in a non-substance use disorder treatment setting. And we see kind of that, this, I'm sorry, I'm just going over it in the, because of time here, but it's providing us service for that yellow circle here, kind of a group that historically would not get services for substance use, and substance misuse in kind of our historical model. That's about 20 to 25% of the population we can see here. Services, this model works with all of the patients and that fit in this entire pyramid, but it specifically addresses that 20% who wouldn't have gotten services in the historic model. So the commonalities here, this is really what I wanted to get at, is that suicide prevention can easily be integrated into the SBIRT model. So we talk about, screening for an SBIRT, for example, tools like the audit, the DAS-10, the CRAFT, the S2BI. For suicide, we talked about these screening tools. We can integrate the PHQ-3 for pre-screening, or even the PHQ-9 when that's already being asked, and then the Columbia screen or the ASQ. For brief intervention, when the screening indicates in SBIRT we conduct the brief negotiated interview, or the BNI. The same goes for suicide. If we identify risk, we conduct a safety planning intervention. And then for extended brief intervention, so in the SBIRT model, when someone would benefit from multiple sessions of brief intervention, we can come for return visits. And in suicide prevention, we have structured phone follow-up, and we, again, can have patients come back into outpatient. And then there's referral as well. So we can refer to outpatient providers, or we can refer to substance use disorder treatment. All right, so thank you very much. I know I tried to cover a lot of information in a short period of time, so I'm going to hand it back over to Dr. McPherson.
Well, thank you, Dr. Harris. Appreciate you sharing all of your knowledge and expertise with us around these important behavioral health concerns, and helping us to understand the research and what the data looks like right now, but also some very practical tools about how you might implement a screening tool, select a screening tool, use technology, and also be thinking more about the intervention. I don't think we hear enough about and even some of that dialogue that you shared. I haven't seen that before, and I think it really is very instructive in conceptualizing how we might integrate this into the practice. Maybe we're doing more substance use, maybe we're doing more mental health, but you've raised up some issues about really needing to be doing these things more routinely. And it really helped me to kind of envision what that looks like and giving some really concrete, actionable tools. So thank you so much for sharing your work and your expertise with us. So in our last few minutes, I just want to remind everyone that you can download the PowerPoint slides and other resources that we've mentioned today, or Dr. Harris has mentioned today, and you can do that on the dedicated website, on our sbirt.webs.com website. And in addition to that, you're going to be receiving a follow-up email from us, and that contains instructions for how to watch it on demand, share it with colleagues, anyone that you think could benefit. It's going to be available 24/7 for them to take advantage of. And you'll also in that email receive information about how to obtain a free certificate of attendance. And last but not least, if you have questions about implementation, evaluation, training around screening and brief intervention, I offer my email address to those who may be interested in a free telephonic technical assistance session, or we can do email exchange if you're looking for particular resources. Some of the resources we shared today are already up on the sbirt.webs.com website, in addition to having links within the PowerPoint. So we're glad to point you to resources that are available out there to help support what you're trying to achieve in your own organizations. In addition to that, I'd like to share with you that there is a 4-part series available using Expert to talk to adolescents about substance use. And so this 4-part series is broken down so that you can take advantage of those that you're most interested in. They are accessible all from our expert.webs.com website. You can click on webinars and see all of these, plus all of them in our library from the last several years. You can download a flyer and share that with colleagues or trainees or students, whoever you're working with you think could benefit from information about this 4-part series. And what you'll notice is it really breaks it down into focusing on screening tools, substance use and mental health, some that Dr. Harris talked about today, as well as kind of breaking down use of the BNI model and MI strategies into 2 parts, and even expanding that to use even more complex skills and integrating CBT strategies. And then last but not least, the 4th part is focusing really on discussing treatment options and using best practices in referral and linkage. In addition, I just mentioned that this 4-part series and really does align with a training manual learner's guide we have available to you, the Learner's Guide to Adolescent Expert. And if you go to the expert.webs.com website and you click on curriculum, you'll be able to request a free electronic copy of that training guide that you can use for self-paced learning or educating and preparing others. So we hope that you'll take advantage of these resources. And with that, let me just thank you again, Dr. Harris, for this terrific session today, and thank all of you for attending and for participating in our webinar series. I hope you have a good rest of the day, and hope you will join us in the future for additional webinars. Have a good day.